Over to you, sir. We are live.
Yeah. Good evening to all of you and welcome to this. Am I audible?
Yes. Yes, sir. Yes.
And welcome to this 31st seminar. Though the name of the seminar is Focused Studies in Breast Cancer, which we are conducting for the last 3 years, virtually every 4 to 8 weeks. This time, the topic that after long discussions, we chose a topic which sometimes on presentation may mimic inflammatory disease, sometimes may mimic cancer, but which is a diagnostic and treatment difficult situation, what we call as idiopathic granulomatous mastitis. And we were all surprised to see that the number of registrations this time has far exceeded than any of the seminar before. With these few words, I welcome to the panelists and welcome to all the delegates. Because of them, this seminar for the last 3 years is a very successful seminar because of the hard work done by some of our younger colleagues. Uh, Particularly, I always mention the name of Dr. Vaishali, uh, Dr. Safalta, Dr. Prekshi, and Dr. Jain. These are the young people who are backbones of this seminar. They do a lot of hard work along with my ideas to make this seminar success. So welcome once again and hand over to the convener.
So today, I am actually going to be talking on the clinical spectrum of idiopathic granulomatous mastitis, and as well as we are going to have a wonderful panel discussion on the same topic. Some of the panelists have already joined. So without wasting any further time, I would actually like to start. I hope my slides are visible.
Yes, ma'am. It is
Okay.
visible.
Yeah. So once again, a very warm welcome to all of you. And as Dr. Rajiv already mentioned that this is a topic which we have actually selected with lot of deliberation because it's a very important topic, and it creates a lot of confusion in our minds regarding the diagnosis as well as the treatment of this condition. And why it is important for all of us is because of the fact that it closely mimics malignancy, and we are always worried when the patient comes to us with a similar situation as to whether we are really missing out on any sinister pathology here or not. So my presentation is going to involve the clinical presentation, diagnostic workup, what are the diagnostic difficulties, and what are the therapeutic options. Guidelines I did mention here, but there are no specific guidelines as to how to manage this disease. So this condition, this challenging clinical condition, was first described in 1972 by Kessler and Wollock. It's relatively uncommon, but it's very difficult, as I mentioned earlier, that it's very difficult to differentiate it clinically as well as radiologically from malignancy. And because there is a lack of consensus regarding the etiology, pathophysiology, and management options, that we have chosen this topic for discussing today. This was initially actually used to be misdiagnosed clinically as breast carcinoma, and in the paper published in 1972 by Kessler and Wollock, they have mentioned that all those 5 cases which they have described in this paper, they were referred to them as malignancies, and those patients were treated with mastectomy. It was later that the mastectomy specimens were actually analyzed histopathologically, and they were found that this is not malignancy, but this is something distinct. And then these two, surgeon scientists have labeled this as granulomatous mastitis. So it was earlier misdiagnosed as breast carcinoma. Then they used to be confused with plasma cell mastitis, fat necrosis, and of course, tubercular mastitis was very common at that time. So it is also called as granulomatous lobular mastitis. It's a benign inflammatory condition of the breast with a pathognomonic feature of epithelioid and multinucleated giant cell granulomas, which are limited to the mammary lobules. So that is how it is actually distinguished from, other tubercular mastitis and all. Microabscess formation without any obvious etiological factor is another important feature which is seen in the pathological specimens of granulomatous mastitis. So when we talk about granulomatous mastitis, it is divided into two distinct subgroups. That is, one is primary or idiopathic granulomatous mastitis, where we are not aware or we are not sure about what is the etiological agent. And then there are specific granulomatous mastitis, like which are associated with other autoimmune disorders or tuberculosis or fungal infections. So the etiological factors which are actually proposed are either as a result of autoimmune, reaction to some unknown agent, or as a direct impact of trauma. It is also considered to be a metabolic disorder, or it is related to hormonal imbalance. And occasionally, an infective agent like Corynebacterium is also implicated in the etiological factor. However, none of them has actually been proved to be, directly leading to the development of granulomatous mastitis. Then there are other potential precipitating factors which have been proposed in different, publications. The important being association with pregnancy and lactation, and other conditions which lead to hyperprolactinemia, use of contraceptive pills, trauma, foreign body infections, smoking, alpha-1 antitrypsin deficiency, and other autoimmune. It is also found to be associated with other autoimmune disorders. However, most women with presenting with IgM do not show any systemic immune abnormalities. The pathophysiology which has been proposed is the major component is related to milk stasis, and that is the reason it is actually seen commonly in association with or in younger women who have recently delivered and undergone have breastfed their children. So it is proposed that the repeated micro trauma during breastfeeding, in addition to the stasis of milk in the milk ducts, leads to triggering of an autoimmune process because of the milk proteins. And this process is actually supplemented by an infective agent called Corynebacterium species that leads to damage to the ductal epithelial lining. And as a result, the ductal contents actually efflux or invade into the adjoining lobular tissue, which leads to local inflammatory response in the lobules. And as a result of this inflammatory response, there is migration of neutrophils and macrophages and other, immunomodulatory cells. And as a result, it leads to non-caseating granuloma formation. And if the process is allowed to continue without any treatment, then there are microabscesses which are formed. These microabscesses can coalesce to form a bigger abscess. So this is a general pathophysiology of this condition which is proposed. This is the same thing. When we talk about clinical presentation, as we mentioned earlier, it is seen in young women of childbearing age, mostly seen in the postpartum phase or occasionally during breastfeeding, stages of the woman's life. It is commonest in third and fourth decade, rarely, very rarely seen in women older than 50. It is common in non-white women, Asians, Hispanics, and Middle Eastern women. There are few case reports where males have also been found to have suffered from granulomatous mastitis, and there are some reports where transgenders have also been found to have granulomatous mastitis. We do not know the exact prevalence of the disease, but one of the papers which was published from Washington, USA, has mentioned that the incidence is nearly around 2.7 per 100,000 population. However, because it is a non-notifiable disease, the exact incidence and prevalence is not known. No association has been found to be between the granulomatous mastitis and future cancer risk. It is rarely seen in nulliparous women. However, hormonal imbalance or hyperestrogenemia is also considered to be one of the potentiating factors. The commonest clinical presentations include palpable tender mass. Occasionally, it can be seen in bilateral and on both the sides. And ill-defined induration with areas of softening is a common clinical finding. Sometimes patients do present with nipple discharge if the the disease process is extensive, then nipple discharge also can be seen. Then regional or focal erythema can also be found, and these areas of abnormality are tender to touch. Skin edema, presence of PDO, all these things actually these definitely lead to confusion, clinical confusion, and we always worry about whether we are dealing with cancer here or not. Then, if the disease process is allowed to progress, if the patient develops recurrent disease, then discharging sinuses are another important clinical finding which we come across. We do see axillary lymphadenopathy in nearly 30% of the cases, but most of them are found to be reactive lymphadenitis. So these are some of the clinical pictures which have been taken from internet as well as some from my own clinical practice. These are the presentations which I have already mentioned. So when we come across such a situation, clinically, we tend to suspect either we are dealing with granulomatous pathologies, it could be bacterial abscess, could be tubercular abscess, could be fungal problem, could be foreign body reaction, fat necrosis, or it could be lactational mastitis if the patient is in that age group. And definitely we have to find out whether it is malignancy or not. Tubercular mastitis is an important actually differential when it comes to situation in India. So how do we proceed? We have to focus on clinical history, especially patients' childbearing history, patients' lactational history, any drug-related, presentation, especially patients have been found to have hyperprolactinemia. If the patient is on antidepressants, so we have to take that history carefully. We have to find out what has been the progression of the disease, whether the patient has started with inflammatory signs and symptoms. All of this is very, very critical before we proceed. And with clinical history taking as well as examination, we come across a situation where we can generally suspect that probably we are not dealing with malignancy, but it could be a condition called as granulomatous mastitis. However, appropriate breast imaging and tissue diagnosis is very important to rule out malignancy and other causes of the presenting condition. Tissue diagnosis is considered to be the gold standard for diagnosis. So the role of serum prolactin and serological markers is actually highly debated. Whether it has any therapeutic implications, we do not know. Imaging X-ray chest is advised to rule out presence of tubercular, chest infections. Ultrasound scan is considered generally to be the first imaging modality of choice. Then we can definitely make use of bilateral digital mammography as well as occasionally MRI breast to, come to corroborate with our clinical findings. As I mentioned, tissue diagnosis is most critical to come to the diagnosis. In addition to that, gram stain, AFB stain, PAS stain, and other stains are critical to rule out other causes of granulomatous mastitis. Culture and sensitivity, although it has been mentioned, but we find that majority of the cases, the cultures come out to be sterile. Gene expert RT-PCR for tuberculosis is also recommended, especially in our situation when we occasionally come across tubercular mastitis as well. Then there are tests which are definitely needed to rule out sarcoidosis also. So when we talk about imaging, there are no pathognomonic features either on ultrasound or mammography or MRI, which will definitely tell us that, yes, we are dealing with granulomatous mastitis and nothing else. However, imaging provides supportive evidence for diagnosis, and it also helps in documenting number, size, and location of the lesions so as to take a decision about what should be the treatment modality which can be offered to the patient. Imaging definitely helps in performing biopsies, guided aspirations, making intralesional injections, monitoring response, and detecting new lesions. So ultrasound scan features usually are non-specific. They can mimic cancer in the form of either skin or trabecular thickening, edema, lymphadenopathy. Usually, the case presents like a lobulated heterogeneous hypoechoic mass, echoic mass, or there can be more number of masses with irregular and angular margins. And some of these features definitely, confuses us whether this is cancer or not. Then there are fluid collections and abscess formation, and sinus tracts also can be seen. Mammography, again, as I mentioned, there are no specific mammographic features of this condition. Usually, patients present with unilateral focal or regional asymmetry with or without associated architectural distortion. Occasionally, this condition can be mammographically occult because patients are usually young. Then breast MRI, it is useful when mammography and ultrasound are not conclusive. And the features which are seen on breast MRI include heterogeneously enhancing or rim-enhancing masses, which may show progressive or plateau type of kinetic curves. T2 hyperintense enhancing mass with or without non-mass-like enhancement is considered to be an important feature found on breast MRI. There are the margins and shapes of the masses can be, variable. They can be circumscribed, round, oval, or irregular. MRI also helps to characterize nipple retraction, sinus tracts, and parenchymal distortion. Tissue diagnosis is the next step, and this is the most important step for diagnosis. Generally, core needle biopsy is what we should be advising because it has got a very high sensitivity. Incisional or excisional biopsies may be needed if core needle biopsy does not give us the answer which we are looking for. FNSC is now actually not considered to be, the pathological modality of choice because it has got a very low sensitivity. The commonest histopathological or pathognomonic features of this condition are lobulocentric granulomas, which are non-caseatic. They are seen in almost 100% of the patients, and addition of Langerhans type of giant cells is also very commonly seen with microabscess formation, necrosis, and neutrophilic eosinophilic infiltrates, interlobular inflammation, fat necrosis, and other changes can also be commonly seen. But the most important, or I would say, commonest feature is lobulocentric granuloma, which is actually helpful in distinguishing this condition from other granulomatous mastitis. These are some of the, pathological features which we have mentioned. Then differential diagnosis actually, by presence of non-caseating lobulocentric granulomas, by presence of localized infiltration of multinucleated giant cells, epithelioid histiocytes, and other cells, organized sterile microabscesses, and very, very rare involvement of ducts and sterile cultures. These are some of the important features which help pathologically in differentiating idiopathic granulomatous mastitis from other conditions which we have already discussed. These are some of the important, conditions which can closely mimic IgM, and these need to be actually ruled out before we come to the confirmatory diagnosis. So these are some of the, workup modalities which help us to differentiate whether we are dealing with some other autoimmune condition or not. So when it comes to the most important aspect of this condition, that is the management of idiopathic granulomatous mastitis, there is a hell lot of confusion as to what should be the initial modality, whether we should treat with surgery, whether we should treat with steroids, how long. There is no absolute consensus about this treatment. It is usually considered to be self-limiting, but it has got a long and protracted course, usually to the tune of, say, maybe few years. But at the same time, a lot of anxiety related to the symptoms, symptom burden, recurrent disease, all of this actually impacts the quality of life of the patient. And as a result, the treatment is very important. There is no consensus, as I mentioned, on what is the optimal treatment. However, a multimodality approach to the treatment, including the medication, surgery, repeated aspirations, these are the ways the patients are usually treated. Observation, antibiotic, steroids, other immunosuppressants, and surgery, these are the mainstay of treatment. of this condition. Observation, as I said, the literature says that nearly 50% of the early presentations resolve spontaneously. In these patients who have very limited or early disease, we can choose to observe this patient, of course, with close follow-up. Um, but that should be done only after confirmation of diagnosis by means of core needle biopsy. And however, these patients may need some symptomatic treatment, some analgesics, in addition to the reassurance. This is what has been actually proposed by Professor Benson in this, article, which was published in 2021. Then, is there any role of antibiotics? This is actually a highly debated, question, which is considered a very critical thing when we talk about granulomatous mastitis. It, as many of these publications have proposed, that Corynebacterium species is commonly associated with this condition, and as a result, many of these case series or individual publications have proposed prolonged use of lipophilic antibiotics like clarithromycin or doxycycline or augmentin, that is amoxiclavulinic acid, for prolonged periods like 7 to 8 months. And in addition to this, it is very important to monitor the response. If the patient shows any signs of improvement, then the authors have proposed that we should actually continue these antibiotics till complete resolution, which can usually take 8 to 9 months. And why? But at the same time, we have seen that the cultures many a times come out to be sterile. Why? The possible causes which are actually proposed for sterile cultures is that patients usually are actually, presenting with previous use of antibiotics, and as a result, the cultures usually come out as sterile. These bacteria are very slow growing and they have fastidious growth requirements. We generally do not use those cultures which are needed for the specific growth of these bacteria, and usually these are the growth, if at all it is shown in the cultures, it is usually dismissed as contaminants, and sometimes the sampling which is sent to the microbiology lab is also inappropriate. As a result, many of the times, even if we order cultures, the cultures come out to be sterile. So it is very debated whether these antibiotics, do they have any role or not. However, some of the papers have definitely mentioned that long-term use of antibiotics may be important for management of this disease. Then steroids. Steroids are the mainstay in the treatment of management of granulomatous mastitis. The first use of steroids was proposed in 1980 for the first time, and it is actually critical to use these, medication in moderate to severe presentation. However, it is important to confirm the diagnosis and to rule out any bacterial infection before we start with steroids, and the patient should not have any contraindication to the steroid therapy. Oral steroids, topical and intralesional steroids are the various ways by which steroids are administered. The important goal of steroid administration earlier was minimal effective dose for short duration. However, it was found that premature tapering of steroids leads to immediate rebound of the condition, and as a result, the papers have mentioned that oral prednisolone should be started with the dose of 30 to 40 milligram per day for over 3 to 6 months. And if the patient is able to tolerate, then the dose can be increased to 60 milligram per day if the patient tolerates and the patient shows any a good clinical response. The proposed schedule for oral steroids is 30 to 40 milligram per day till we start seeing the response. That might usually take 4 to 6 weeks, and gradually the tapering of the dose can be done to 20 milligram per day over 2 to 4 weeks gradually. And once the tapering is done to 20 milligram per day, we can actually continue that for 3 to 6 months and very, very gradually reduce maybe by 5 milligram, at one time for 3 to 6 months. And then if the patient shows complete response, it can be discontinued. Topical steroids are also found to be effective in the treatment of idiopathic granulomatous mastitis. Steroid pomades, creams, ointments are proposed for the use. Prednisolone 0.125% or triamcinolone 0.1% twice a day on alternate days for 4 days a week for 6 to 8 weeks has been proposed. These type of modality of treatment has been found to have less side effects compared to the oral steroid preparations, and they have been found to have good resolution of fistulae and sinuses. In addition to the topical steroids, combined intralesional steroid and topical steroid administration has been found to be more efficacious. So intralesional triamcinolone acetinoid injection in the dose of 20 milligram per cubic centimeter in the center of the lesion once a month under imaging guidance. In addition, triamcinolone acetonide topical administration is recommended. For this kind of treatment, a repeat ultrasound scan should be done every month, and repeat injections should be done monthly till the resolution is complete. And usually 3 to 4 such injections are required. That is what the paper suggests. If the patient has got an extensive and diffuse disease, then multiple sites of injections can be done. And if there are multiple lesions, then each lesion can be individually injected separately. The intralesional injections have been found to have equivalent efficacy and less systemic side effects. However, the exact duration of treatment and how long does it take for the entire disease to resolve completely is actually not known. And it has also been mentioned that sustained response may or may not be observed. So it is very difficult to understand whether we can continue only with injectable or intralesional steroids, or oral steroids also need to be supplemented. So when we talk about steroid treatment, there are obviously side effects of prolonged therapy like mood changes, weight gain, elevated blood pressure, sugar intolerance, and all of that. So that is the reason actually patients are very reluctant to continue use of steroid for a long duration. Some non-steroidal immunosuppressants have also been proposed. Methotrexate in the dose of 10 to 15 milligram weekly for a duration of 3 to 6 months and with slow tapering. The symptom resolution rates are approximately 83%. However, there are recurrences as well to the tune of 70 to 20%. And similar actually, rebound phenomena are seen with oral steroids as well. Other immunosuppressants which have been utilized are azathioprine, mycophenolate, mofetil, and all that. But however, the experience is limited. Surgery, yes, it is important, and all of us, are usually the surgeons are usually the people who deal with granulomatous mastitis. It was the only treatment which was proposed for this condition till 1980s. It was actually found that surgery, although it may be done with good margins, but it does not prevent recurrences. So the recurrences which have been, found in published literature are reported to the tune of 5 to 55%. It is actually limited to those patients who are non-responders to steroid treatment or those who have severe symptoms, abscess formation, or fistulae formation. And these patients may need multiple surgeries to achieve remission. And when we talk about excision of large masses, definitely that leads to inevitable cosmetic outcome and unsightly scars. Mastectomy with breast reconstruction has also been performed for some patients. However, this leads to huge psychological and financial impact and is not a routinely recommended procedure. When we talk about surgery for early disease, it is considered ideal for localized, uncomplicated, very small lesions when you are able to excise the lesion with a good margin of healthy tissue and there is no sign of skin involvement or impending fistula formation. When the disease can be excised with a clear margin so that the patient does not need any subsequent adjuvant oral steroids. The other modalities of interventions can be repeated ultrasound guided aspirations if the patient develops pus formation, incision drainage, or surgical debridement may be required. Wide local excision, I already mentioned. Partial mastectomy with volume replacement can also be performed. Mastectomy, very, very, very rarely with, for patients who have intractable disease. And patients may need surgical intervention for percutaneous drainage with or without fistula tract removal. It is proposed that the excised raw area should be left for secondary healing, and later on maybe delayed fat grafting or autologous flap may be used for replacing the lost volume. This is the I have taken this from this paper. The authors have actually showcased one case where a wide excision of the involved part of the breast was done and it was replaced with latissimus dorsi flap. So this is the management algorithm. When the true cut biopsy shows that it is granulomatous mastitis, if it is a localized small lesion, then you can either observe, or if the patient needs or wishes for surgery, then surgical excision with negative margins if it is going to preserve the cosmetic outcome. If it resolves, good, well and good. If there is recurrence, then you can start with steroid or methotrexate therapy. For borderline lesions, depending on the patient preference, whether to start with medical treatment or surgical excision definitely needs to be counseled after a good counseling session. For large and diffuse complicated lesions, definitely start with oral steroids or intralesional steroids. If the lesions resolve, fine, and observe. And if there is failure of the treatment, then surgery is the ultimate modality of option for this patient. There have been some papers, and especially this paper, which is published, the meta-analysis of comparison of conservation versus surgical management protocol for this condition. It has been found that there is no significant difference in the recurrence rates of IgM after surgical or medical or conservative approaches. Multiple surgeries have been found to lead to higher probability of wound infection, sinus formation, and definitely cosmetic deformities. Hence, the pharmaceutical approach with or without surgery is strongly recommended as the first modality of treatment. Surgery is recommended for recurrent patients or patients who have lack of response to pharmaceutical treatment. So, to conclude, before I conclude, I would say that idiopathic granulomatous mastitis is a rapidly progressive inflammatory condition. The clinical and imaging features actually trouble us. They mimic breast carcinoma. The other important troubling part is that there is lack of consensus on what is the optimal management of the disease. There are recurrent episodes and patients definitely are symptomatic, leads to a lot of scarring, breast deformity, and patient and the family members are always anxious about this condition. So this treatment, actually this condition needs to be treated as a teamwork. We have to go hand in hand with our pathology and radiology colleague. And of course, the patient and her loved ones have to be reassured, counseled at multiple times so that the patients, don't lose hope in the treatment. And that is how I'm going to conclude my talk and will move ahead.
Thank you, Dr. Vaishali, for a wonderful talk for a disease which is less understood and less well managed. So it's time for the panel discussion. Actually, I was supposed to moderate this panel discussion, but my throat is bad. So I have requested my colleague Vaishali only to continue with this as a moderator to this panel discussion. We have a very, very learned panel today. Just to introduce in short, Dr. Geeta. We all know almost. Dr. Anand Mishra is professor at Department of University. Dr. Swagda is from All India Institute of Medical Sciences, Bhopal. Dr. Jyoti is a colleague at Medanta, a dedicated breast radiologist, now in the town for almost 14-15 years. And Dr. Kavita is a pathologist at MEX Super Specialty Hospital, Shalimar Bagh. Over to Vaishali, please, for conducting the session.
Thank you, sir. Let me just, yeah. Is the slide visible? Are my
No,
slides
not yet.
visible?
no, no.
Not
Not
yet.
yet.
No.
Okay. Just a moment. Just a moment. Give me a minute. No, this is not the one. Sorry.
I think, Dr. Vaishali, we could maybe start some of the
Sir,
discussion.
just a moment. Just a moment. I hope now. Is it visible?
Yes.
Yes.
Yes,
Okay,
yes.
okay. So, welcome to all my panelists. Dr. Rajiv has already welcomed them. So, I'm just quickly going to show you one case and then we will actually move on with the discussion. So, this lady came in October to me. She's a 34-year-old premenopausal mother of two. Having delivered her last child 5 years ago. She presented with a lump in left breast, progressively increasing in size for last 4 months, and recently she noticed nipple retraction. She also had some mild tolerable pain in left breast, no fever, and no other significant past and family history. This is how she presented with a left breast bigger looking than the right one and a large palpable ill defined lump in the upper inner quadrant. So the before actually I'll proceed with the other findings, I would actually like to ask all my panelists, especially the surgeons, Dr. Geeta, Dr. Swagata, Dr. Anand, and Dr. Anupma, one by one maybe, how frequently do you see, patients with granulomatous mastitis? Dr. Geeta?
So, it is variable. They come in crops. Sometimes
Yeah.
in a month, you'll be seeing about 3 of them. And essentially, in a year, I would say we are close to 15 to 20 cases of granulomatous mastitis, I would think, in a year.
In a year. And Dr. Anupma?
I would say it's more than that. Like every day, I'm seeing about at least 2, 3, but many of them are follow-ups. So new cases would be maybe 5 to 10 in a month.
Okay, that's quite a
That's
large
a high
number.
number.
That's a high
That's a high
number.
number. That's a high
Yeah. So,
number. Yes.
Dr. Swagata and Dr. Anand both represent, public sector large hospitals. So, is the number higher in your centers or similar?
It is more or
Yes.
less similar.
Similar. Okay. And what are the common presentations with which you come across such patients? Is it a mass or what? What?
Tender mass and
Anyway,
sinuses and discharging sinuses.
discharging sinuses. Dr. Geeta?
So sometimes, you may not have a tender lump. It is just a lump. It's a large lump. And you almost think that, oh
Large.
God, this young woman has got a
Mhm.
cancer. But
Mhm.
it is an ill-defined thing. It is large. It is of recent origin,
Mhm.
say a month, and it's kind of rapidly grown to that size. But it's not a phyllodes because it doesn't feel like a phyllodes. It is just a lump with ill-defined margins. Um, and sometimes I've had patients who've come simultaneously with joint pains also. So you have
Mhm.
somebody complaining of ankle pain, somebody having elbow,
Mhm.
shoulder,
Mhm.
and all of this has happened kind of simultaneously. Sometimes the joint pains may precede the occurrence of the lump.
Okay. So, Dr. Anupma, like Dr. Geeta has mentioned, what are those features which,
Other than, of
you
course, the
know,
sinuses and all of those, that is a different thing. But otherwise, you do get to see.
yeah. So, I was asking Dr. Anupma, what are those clinical findings or, clinical features which probably allow you to think that probably you are not dealing with cancer here, but it could be granulomatous mastitis. Is there anything else which you would, add to what Dr. Geeta has already mentioned?
So basically, softening of the lump or, clear-cut abscesses, clinically you can make out it's an abscess. So that would definitely tell you that it's unlikely to be a malignancy and more likely to be granulomatous.
Right. So now when you come across such a situation, what is your, first modality of investigation, I would say? How do you proceed
So first
clinically?
would be ultrasound. First would be
First will be.
ultrasound, yeah.
Uh-huh.
And that will give us a very fair idea because I think ultrasound is quite good in detecting this kind of ill-defined diffuse mastitis, the sinus tracts and the collections, multiple abscesses all over. That gives us a fair idea that we are dealing with this.
Right. Dr. Jyoti, do you agree with this? And what will you prefer to evaluate this patient as a first modality of treatment?
Yeah, she's 34, and so my first choice would be ultrasound. And as you said, like clinically also, it's pointing more towards inflammation. So there is no reason to start with mammo. We would start with an ultrasound first. And usually in such cases, what we see would be an irregular hypoechoic areas which have those branching patterns or tentacles. Then there would be streaks of fluid, skin thickening, a lot of edema, and the tentacles or the branching tubular areas of breakdown that we see is because they are insinuating or going around the fat lobules. That's why we see them. They are not penetrating into the fat lobules, so that those kind of appearances give us a very good hint that this is more likely to be an inflammatory lesion rather than cancer. But saying this, when they come in the very, very initial phase, when the areas of breakdown have not yet started. Once the areas of breakdown are there, then internally we see mobile echoes. It's much more easier to tell us. But in the
Right.
very, very initial stage, when it's all like an inflammatory soft tissue going along the ducts, we do get confused with the non-mass findings that we see on ultrasound, which are very indicative of DCIS or ductal etiology, sinister etiology. And then when it is at that stage, very early stage, where it's very difficult, and even on the MR, they show us the typical segmental non-mass enhancement with clustered ring appearances and
Right.
no abscess formation yet. So these are the areas, these are the times when we also do get confused that is it really malignancy, because there are no areas of breakdown, no discharging sinuses, no tracking along the fat globules reaching up till the skin. So that is the time when I would definitely go for an MR, provided, oh sorry, go for a mammo first, provided the patient is not, in a lot of pain. And
Right.
at times, if it is DCIS, I've seen a lot of time there would be some microcalcification, which really helps me to make my, decision whether this is inflammation or this is just, or is it like a malignant etiology. The other thing is, most of the times, when you have those segmental areas of involvement, the discharge here would be pus or milky discharge that would be coming, or but if it is DCIS or a malignant etiology, if we are dealing with bloody nipple discharge, then although the appearances on ultrasound might be similar, I would be thinking more in terms of malignancy then. So clinical
Right.
information help us, microcalcification help us, and if we can see areas of breakdown, that's the time when we are much more confidence saying this is more likely to be an inflammatory etiology
Right.
rather than malignant.
So I think we all would agree here that many a times we need to, involve the help of ultrasound, mammography, as well as MRI to, uh, get as much information as is actually possible, especially in such young women. Like we previously mentioned that mammography may not be a first modality of choice here, because one is because the women are young, the other is because there's a lot of discomfort as well. But sometimes, as Dr. Jyoti has mentioned, the presence of microcalcification can also help us to decide whether this is DCIS we are dealing with, or it's something else. So this lady has undergone ultrasound elsewhere. I don't have the images, which was reported as diffuse fibroglandular parenchymal tissue with increased echogenicity and an ill-defined irregular hypoechoic lesion in the upper inner quadrant, and it was labeled as query fibroadenosis. So the person who was initially treating her also advised her to go for a mammogram. This was what it showed. It showed an irregular, ill-defined area of density with architectural distortion in the inner central quadrant of the left breast. Dr. Jyoti, is there anything else which you would comment on this mammogram? I mean, the quality of the picture is not that great, but is there anything else which
So basically,
yeah.
I would really look for if I can see, because if you see, it is more like a segmental, and the distortion that we are talking about, it's actually all thickened ducts on the
Yeah,
ultrasound will be very, it will be much more clearer. So they
right,
are coming in one segment and the ducts are thickened. So I would really look for any microcalcifications. Now, I don't think so, but then obviously it's very hard without a mag view. So
right,
yes, I would at this stage, unless I see an ultrasound, I would keep both my malignant etiology and an inflammatory lesion in my differentials, because I'm not seeing any skin thickening. There are
right,
no microcalcification, but there is distortion, which is very, a sign of sinister etiology. So I'll keep both of them in mind.
right. So when she came to me, this is what she came with, an ultrasound and a unilateral mammogram, and the clinical picture was quite sinister looking, with lot of edema and an ill-defined lump, and it was quite firm in the beginning. So I also ordered an MRI. These are the MRI pictures, and the reporting was with minimal background enhancement, an irregular mass with clumped non-mass like enhancement and all that. And it was reported as MR by RADS 5. Obviously, there were linear clustered ring and clumped NMLE in the upper inner quadrant with skin thickening, nipple retraction, and washout kinetics. So with these findings, definitely it was labeled as MR by RADS 5. Um, then, since she had a clinically palpable node, the FNAC of the node was also carried out. It was reported as no evidence of malignancy, no granuloma. So, obviously, the next, I'm sure all the colleagues would agree that the next modality of, investigation would be a core biopsy. Is there anything else, Dr. Geeta, you would like to do before we proceed with tissue diagnosis?
So, if there is frank abscess or a frank purulent discharge coming, I would wait for the abscess needs to be dealt with, because at that time, if you do a biopsy, you may just land up getting some acute mastitis or something like that, because that happens often. But I've also had a patient who came to me with an FNAC which said ductal carcinoma. But when you look at it and you see that it is not, so I was almost convinced when I saw her, because she had a small sinus just a little away from the mass. And then we did a biopsy, and that came back as chronic granulomatous mastitis. Okay. So I think that is the limitation. I would certainly want a biopsy, But sometimes I think granulomatous mastitis is underreported.
Right.
So you need an experienced pathologist also to be reporting with confidence on an IgM, because a lot of times you just write granulomatous mastitis and leave it to you to figure out whether it is COX or it is IgM.
Correct. Correct.
But I can assure you
Sorry, go ahead.
So what I can assure you, what has happened is there has been a mind shift on our part also, because earlier we would kind of be more happy, trigger happy, I would say, and start off ATT, but now in the last 4 or 5 years, I have seen that I've been completely wrong on several occasions, I think, in the past. But I can also say that, AKT also will work, because this is long-term antibiotics you're giving for 6 months, and you will get the response. But I think we have wrongly labeled a lot of patients as tubercular mastitis instead of IgM.
Correct. So it is very common to see that the patients, come with somebody else starting, having started on AKT. So at this stage, if the patient has already been put on anti-tubercular treatment, would you stop the treatment right away, or would you do in this situation? If the patient comes to you like this, and she's already being put on, empirical anti-tubercular treatment, would you
So one thing
advise
that
her?
is one thing that has to be very, very clear is that we should, stay away from doing an empirical ATT. There are a lot of medical legal implications also to it, and we should be very, very careful when to, do an ATT. Without proof, we'll be kind of going to land in trouble.
Right.
So that is one thing that we have to be very careful about. But if somebody has already started, the thing is, we must understand, if the patient does not have tuberculosis and you're just putting her on AKT, and if she's IgM, she's going to get worse on it, because this patient possibly required antibiotics and required steroids and the immunomodulators and all of that. But if it is not, if it is actually tubercular and you want to do steroids, it'll get worse again. So, we are caught in a catch-22 situation. You do this, you get into trouble. You do that, you still get into trouble. So, so it is a conundrum. I'll completely agree, and it requires a lot of patience on the part of the treating surgeon as well as the patient.
Yeah. So coming on to Dr. Anand, do you also come across such a situation that the patient is already on anti-tubercular treatment, or you start anti-tubercular treatment in this situation? What is your take on this?
So the first situation is very common. I mean, patients are started in peripheral areas on tuberculosis drugs after these diagnosis of FNAC, and then we don't start empirical anti-tubercular. We never use. There has to be some evidence. Only then we will have anti-tubercular. Patient will get anti-tubercular, and also this will be in consultation with our tuberculosis department only.
Right.
Everything.
Dr.
Because
Swagata,
it's a notified and notified disease, and there are issues with the medical legal issues. So
yes,
most of the time, if there are any evidence, we will have consultation.
correct. Dr. Swagata, when a patient presents with significant inflammatory changes, signs and symptoms, and granulomatous mastitis, do you start with some antibiotic and wait, and then maybe go for biopsy? What has been your practice so far?
See, I start antibiotic and with a broad spectrum antibiotic, generally with augmentin, and put the patient for the cord cut biopsy, wait for the report, and if there is some discharge, I go in for culture, which usually comes at non-sterile or contaminant of 3 bacteria, because the culture material is very small. If it is generally it comes as contaminant or sterile. So I start with a augmentin, wait for the culture report and a tissue biopsy. If it comes at granulomatous tuberculosis to be ruled out with CB-NAT, if tuberculosis is ruled out, and a fungal culture, generally I give all to my patients, because in AIMS we are having a fungal, very excellent fungal culture department. So after that, if everything is negative, I continue with antibiotics for 1 month. Initially augmentin, then with doxy, then with clazithromycin, if patient is responding.
Okay.
And
So, Dr. Anupma,
granulomatous mastitis diagnosis.
okay. Dr. Anupma, is it similar you do in your practice or something else?
No, it is quite similar. So basically, I do an ultrasound guided aspiration of the pus, send it off for gram stain, AFB stain, fungal stain, aerobic cultures, and take a core biopsy from the lesion or the wall of the abscess. And
Right.
while all these reports are being done, it takes about a week. Start her on antibiotics, call her after a week, and then reevaluate everything.
Okay, thanks. So we'll now move to Dr. Kavita, the most important, person in the, diagnostic journey of this disease, granulomatous mastitis. Dr. Kavita,
Yes, ma'am.
so let us, ask you about the what are the clinchers, the pathological clinchers, which tell you that this is IgM and nothing else. So I'm going to show your slides, but can you just elaborate on what all things you look for before you label it as, granulomatous mastitis?
Yes, ma'am. So actually, first of all, this is a diagnosis of exclusion, as all of us are aware that we have to undergo so many other tests, so that we have to rule out other conditions, and so that finally we come to this.
Correct.
So of course, as we have discussed elaborately, I would give a gist that whenever a patient comes to you for this diagnosis, I think as ma'am had just mentioned, Dr. Swagata, that we have to take an aspirate for AFB culture. And then, of course, I think the TB PCRs, generally we are, I think the clinicians generally, they say that the biopsy, the block we can give for TB PCRs, but no. I would say a fresh tissue in normal saline should be sent for TB PCR. So the complete workup would be an aspirate for culture as well as for staining, for AFB stain. Then fresh tissue in normal saline for TB PCR. And then, of course, a biopsy. But here, I would just like to disagree, ma'am, that how does a core biopsy actually, can we see the next slide? So the pathognomic feature, as I have shown here, is a lobulocentric granulomatous inflammation, which has been, I think, your lecture included it very well. So we have a lobulocentric inflammation. And we see around of course, as our radiologist said, that initially when the patient presents in initial stage, they can see the architecture maintained. So that corroborates with the pathologic diagnosis also, because the lobules are very well maintained in the most of the times, and we see a lobulocentric inflammation with neutrophils. There should be no necrosis. These are the two pathognomic features which should clinch the diagnosis of granulomatous idiopathic.
Okay.
So I just wanted to know that if you give us a core, so many times it is not possible that we get the lobular architecture intact. So at that moment, the pathologist may, they may miss it. They may just call it acute on chronic mastitis. So this is a question to all the surgeons. Is it possible that we obtain a good chunk of incisional biopsy to get a proper diagnosis? Is it possible, or is it doable?
Dr. Geeta, anyone, Dr. Anand, Swagata, Dr. Anupma?
It is possible, but it does mean that,
most of the cases, we get for review. Most of them have been diagnosed as acute on chronic mastitis. And definitely, even on incisional, if the people are not aware of this condition or the type of the pathognomic features, they definitely miss it. So, I mean, at the first hand,
definitely, incisional biopsy, it is possible, but definitely it is more invasive than a coronary biopsy, and would definitely lead to scarring if the patient, that is what.
But Vaishali,
more than that, Vaishali, what happens with
yes, go ahead, Dr. Geeta.
Go ahead, Anupma.
Yeah, no, I just wanted to say that if it is so important for us to get the correct diagnosis, Just doing an incision biopsy is quite okay, you know. I mean, rather than missing out on the diagnosis again and again, doing a repeat core, sometimes you do a repeat core also. Because you, on the first core, you got a acute and chronic mastitis. So, you know, doing an
So a lot
incision
of times what
biopsy
happens is
makes
you are
sense,
treating
actually.
I just wanted to add, Dr. Kavita, like being a radiologist, do you think if we take more
acute
course that help us? Because in our institute, our
acute
pathologists are
basis
able to
when you
give us
land up
this
where
sorry? Yeah, our pathologists are able to give us the diagnosis of IgM in a lot of cases. And is the number of course that we are taking, or from where exactly we are taking, like for example, rather than going into the necrotic or the area of breakdown, if we are taking it
Absolutely.
more
Yeah,
from the
that can be
walls,
done.
would that
Yes,
help? So
agree.
like, you know, I can see there is a little reservation among the surgeons to do an incisional, but why not try to improvise the already the current technique, because a lot of us are getting it right also.
No, I
Yeah,
totally agree. But mostly
agree.
the biopsy is done at the periphery, you know, as you said that if you are keeping that condition in mind, you're aware of that differential in mind, you will definitely look up to areas where, you know, you find a viable this thing. Definitely more number of fours. If we get a lobule, nothing like that. Yes, I totally
I
agree.
think that is the, you know, the critical thing is to do an image guided core biopsy.
Yes.
Obviously, with people like Dr. Jyoti, definitely they would do the, you know, great job. Dr. Goel has raised his hand. Sir, कुछ कहना चाह रहे हैं?
I just wanted to ask the panelists also. Say, Dr. Kavita mentioned that sometimes we get a report of acute and chronic mastitis, or basically something which is not typically reported as a sort of granulomatous mastitis, but overall the clinical picture is, let us say, compatible, because there is no other sort of history suggestive of a recent acute episode or antibiotic therapy converting into a mix of acute and chronic. Then would you keep on repeating biopsies till you get granulomas, or would you go with a combination of clinical, radiological, and whatever pathological information is available? So that maybe the surgeons, I would like their comment.
So if you ask me, we do get this situation all the time. You get an acute on chronic mastitis report. And, you know, I cannot possibly start her on steroids or even ask my rheumatology colleague to, you know, think about an immunomodulator at that point of time. So eventually what happens is, after 1 month of trying various antibiotics and anti-inflammatories, if it is still not working out, I don't have an option other than to go ahead and operate that patient. And it is on the final pathology that you get a chronic granulomatous mastitis, and then you go back to the drawing board and start off medical treatment again.
So,
We
Dr.
had,
Anupma,
sorry,
So,
we had a couple of such patients. They had acute on chronic, and then nothing was working. And then the next time when they came, we repeated them with VAB, and then we got granulomatous IgM in their diagnosis. And then they were put on steroid, and they complete this thing. So that is also an option if the results are not you know, the desired, or a result which is fitting into the clinical and the radiological picture is not achievable in the first attempt, then we can even think of that.
So how many cores we should take? I mean, in place of, if we are not doing incisional biopsy, how many cores at least the pathologist should?
That is actually really subjective. As Dr. Jyoti said, yes, ultrasound guided would help. I think the size or thickness of pores matters because I believe that if they are thick pores, we will be more. There is a possibility that we get a lobule, intact lobule, or something like that.
So basically, if I'm getting sinkers in full length, then I sort of stop at 4 or 5. But if I'm getting very fragmented tissue, necrotic tissue, which is floating, then I would even at times go to 7 or 8. So
and I would
I
like
see,
to
I would see the quality of the course that I'm getting. in my specimen bottle, and I keep looking from the bottom how many of them have sank down and how many of them are full length. So that really helps me to decide when to stop. And when I'm targeting, I would not generally target the center of the lesion, because that is where I'll get the necrotic tissue. I would be targeting the wall of the lesion.
Other thing I would like to bring to notice that we should start sending a core, one or two cores for TB PCRs also. I think in normal saline.
In saline, right? In
later,
saline.
because we get the requisitions that send it for TB PCR, but the fixed specimens cannot work for TB PCR.
Correct. I mean, that's really actually important to obtain the appropriate sample for accurate diagnosis. My next question to all the surgeons is: have you come across any such a situation where the initial diagnosis was the pathological reporting was acute on chronic mastitis, and we got a shock later on that it was actually indeed malignancy and not mastitis? Have you come across any such situation?
Not yet.
Not.
Ma'am, I have come across one case. She was a young female.
I've also recently come across one.
Okay.
Yeah, go ahead, Kavita.
ये उसको इनिशियली FNAC पे एब्सेस था, तो ठीक है, फिर उसका एब्सेस उन्होंने निकाला. मैम, वी हैड by chance we processed the entire cyst wall, and एक 5 millimeter था जहाँ पे ट्रिपल नेगेटिव ब्रेस्ट कैंसर was sitting. बाकी सब एब्सेस था. Absolutely.
Dr. Geeta?
So one that I saw was 37 years old. She recently came to me, had an abscess drained in April of 2023. So what she is saying is, after that, soon after the abscess was drained, she was well for about 2 or 3 months. But of course, dressings and all were happening. And the biopsy report was, again, acute on chronic mastitis. It did not say IgM.
Okay.
And then she continued to have a discharge, and there was something hard was coming up, but she was going to the same doctor. They could not really. So then she was referred to me, and when I examined her, of course there was a poderange, not very large area of poderange, but just at 12 o'clock there was a hard lump with a limited poderange, and she had a lymph node also. And in fact, the first biopsy from the lump, I don't know for what reason, it came back as negative, because I think it did not hit target. But I also asked for an FNAC of the lymph node. The lymph node was metastatic. So we repeated the biopsy, and we got an ER/PR positive, HER2 negative breast cancer.
So I think that is what is very important to, I'm always, worried as to. Can you mute person who's talking? Yes, sir. Dr. Goel, yes.
Ma'am, can I quickly go through this?
Can Dr. Manju be muted?
Can I quickly go through this?
Priyansha, can you mute Dr. Manju? Yeah, sure.
Yes, Dr. Kavita.
So, ma'am, the variant of granulomatous mastitis, which I have seen just one case, or I shall say I've recognized one case till now, cystic neutrophilic granulomatous mastitis. And this case had come to us for a review, again saying acute on chronic mastitis. And when I saw it, I could see some ill-formed granulomas, which I'm sure could have been easily missed by the pathologist.
Okay.
And then I saw these lipid vacuoles, the clear spaces. So it just clicked that could it be a differential? I think I spoke to Dr. Geeta ma'am also, ma'am, how frequently you see cystic neutrophilic granulomatous mastitis before I reported. So I worked it up. I took thick sections for corynebacterium bacterium stain. Gram stain, to look for corynebacterium. And luckily, we got gram positive. Although this is not the case, this I took from internet, but we had similar picture, and my microbiologist confirmed that. So the patient was taken, I think she was given doxycycline for a long time. The clinician said that 6 months, 8 months, the patient is okay. She did not come back. But I think this is one condition which should be definitely, you should look for it.
I've recently seen one of cystic neutrophilic granulomatous mastitis and remembered that you told me this the separate entity, but I have not done this stain on her. So maybe I should.
It is, I mean, the literature says that, it is very difficult to prove it on cultures.
It has a different culture medium.
It has a different culture medium, which is,
really not
yeah, right. So now let us come to the treatment part. And that's the most important part of, today's discussion. How do you proceed when what has been your treatment algorithm? How do you take a decision about how to proceed with treatment? Anybody, Dr. Anand, Dr. Anupma, Dr. Geeta. Dr. Anand, let's start with you. How do you decide whether to start with antibiotic or steroids or how? Sir, please unmute yourself.
So depending on the presentation, if there is a pus, so we have pus cultures and AFB and all types of cultures. And if there is any evidence of any antibiotic, I mean specific bacteria, or so it will be a specific antibiotic. Otherwise, we have choices of, we have been discussing amoxiclavulanic or linezolid, levofloxacin, doxycycline, or clarithromycin. So these are the choices. Depending on cultures and all reports, we use these antibiotics. And then if it is a small in one quadrant, then we prefer to give intralesional steroids, ultrasound guided intralesional. We I mean in our department only, we use our with our ultrasound in the evening, same day in the OPD procedure. After OPD we will do it. And if it is large, involving more part of the breast, I mean more than one quadrant, then in that situation it may be an oral antibiotic. But initially, if there are signs of inflammation, redness, erythema, then definitely antibiotic. Then later we go to the steroid thing.
Okay.
And these all continues. We usually give these intralesional steroids twice weekly, and at least 4 to 5 times. Yeah, most of the people, they use it monthly or 3 weekly. We use it twice weekly, and then 4 to 5 cycles. And if when it becomes stable, then we don't give intralesional. And that is the time when we have to take a choice whether we just keep these patients on follow-up, or we go for surgical excision when it has localized.
Dr. Anupma?
Yeah, something similar. So depending on the severity of the disease. So if it is just a very mild, a small lump, not really causing much symptoms, then we even give them antibiotics for about 1 to 2 weeks and keep them on follow-up, just observation also. Call them again after a month. And if it is moderate to severe cases, that means large lumps and abscesses and all, then obviously ultrasound guided aspirations, and we start with oral steroids. And oral steroids in the dose of 0.5 to 1 milligram per kg per day. And the most important thing is telling the patient that this is going to take time. 3 to 6 months usually is the time that it takes, and to tell them to have patience for that time. Because otherwise, they just stop the steroids on their own, and they go here and there. They go around changing doctors and all that. That happens so commonly that you land up with more problems later.
Right.
So I guess the counseling is the most important part of the treatment of this disease.
Yes. So that is what was my next question was, what has been the compliance of the patient to the treatment? So you answered that. Dr. Swagata, is there any different, approach you take for managing these patients?
With steroid, if it is not responding, I give less steroid for 1 month only. I give, and it cured the sinuses for enhanced healing, and send the curettings again for tissue biopsy, etc., to see if I have missed anything. And recently, in 3 or 4 of my patients, I have started with the immunomodulator Guduchi, and not yet in a condition to say whether it is really working, because it is very few in number, but I found very good results.
Okay. Dr. Geeta, your use of steroid of choice, intralesional or oral?
So just as Dr. Anand said, I would do it for a small lesion. So if it is a 2 centimeter thing and you've been able to aspirate some of it, put her on antibiotics, and then once you see that it has started to respond, then I would do a steroid for that small lesion. But if it is big, then I would do oral steroids after I've done a couple of weeks, just as everybody else is doing, a couple of weeks of antibiotics. The other thing that I've started doing now is I have found an ally in a rheumatologist, because I have realized that, and the results are great. I'm very happy because, the patient is also happy because there is another shoulder to cry on, because, it can be a very difficult disease to treat.
It
But
definitely
once
gives
they,
us confidence as well.
yeah, and the rheumatologist is very confident about bringing in various immunomodulators. I spoke to him and I said, how do you decide when methotrexate, when the HCQS? He says there is an algorithm which they follow and they do it on a case-to-case basis. And I see that they use methotrexate more freely than we would think. They would start off with a 7.5 milligram weekly and put them on Folvite and all of that. So they are taking care of the entire spectrum. So I hit upon this idea by serendipity, because I told you, because there is this patient who came with a couple of patients who came with joint pains. And I said, okay, let's seek the help of the rheumatologist. And we realized that what he was doing was working well both in the breast and the joints, So I have made this a regular practice now. So the patient comes back to me only when there is an aggravation, there is abscess formation. So there is one patient who I told you, who said malignancy on FNAC. So it's almost 2 years, and there is a pattern to it. She says that every January, end of January, there is an aggravation. So she has been with the rheumatologist. He has been taking care of all her, the autoimmune bit. And when now again she's developed an abscess, she came back to me. I aspirated once and put her on antibiotics. And once it settles down, she goes back to the rheumatologist. So it's a great relationship. I think it is working very well for me. And I'm sure, I think we should all think about it.
So it is a known link, actually. Approximately
Yes.
8 to 14% of the patients, they have other autoimmune disorders like joint pains
That's
and
right.
erythema nodosum and all that.
Erythema nodosum, yes.
Correct. And during this treatment, how frequently and with what modality do you monitor these patients for response? One by one, maybe you all can.
It's a clinical judgment. I mean, patient is improving. Patient says that lump has gone decreased. There is an sinuses have healed, and then clinical, as then ultrasound is the other modality.
Yeah, I'll agree, I suppose. Right.
Yeah.
And then that is how it helps us to modify the doses, maybe add something else, or administer more intralesional and all that. That is how. Is there any situation where you would operate first in granulomatosis mastitis? But Dr. Anand has already mentioned that when the patient has a large abscess or fistula, is there any condition or any patient where you would operate when there is no sinus, no fistula, but you
want to say that patient presents with lump only in that situation?
That's what I'm asking. Where would you take a decision about surgery first?
So not truly. Initially, we try this all modalities, then only later on only surgery for the residual lesion.
All of you agree?
I think it is important for the patient also to understand this, that everything possible to take care of in a conservative manner has not worked, and then you operate. And it is not as if surgery does not give you good results. But the thing is, we have to keep telling the patient, look, whatever I may do, you're still going to come back. And you're going to continue to change doctors also. So I think that's okay.
Correct. I actually want to come back to Dr. Jyoti. Dr. Jyoti, when we do, say, serial ultrasounds, what do we come to know about, I mean, how the patient is responding? How does the, ultrasound picture change with treatment?
So if it is a unifocal, obviously, then the size is a very good criteria. So if it is unifocal, one single lesion, we'll see a decrease in the size. There'll be reduction in the surrounding edema around the lesion. But if it is multifocal, those tubular branching pattern where they
So,
are interconnected with each other, they can be at times
when
really
you already have the knowledge
difficult
of
to
how many
say
children are on prophylaxis.
whether the patient
So I
has
have seen this
responded or not. But
in
yes, reduction in
one of the
edema,
centers which I
those
was
branching
fortunate to visit
tubular
in the Europe.
hypoechogenicity, they start to collapse. So the
The
thickness
the
of these
PWH are
reduces. But what I generally tend to do is, I would say that it is extending from say 9 o'clock to 1 o'clock position, and then take multiple pictures. So when in those cases, if there is a reduction in the outer in the extent from 9, it might now go to 10, and from 1 it is coming to say 12, then it's easier. But this may not happen all the time. There might be a piecemeal response and not concentric response. So it's the thickness of those branches, but more importantly, the edema goes down, and we have to go back and see the images, how the number of those areas of breakdown, and they might have reduced now. So that becomes a little bit difficult. But then having saving good number of images and then going back and comparing, we are able to tell that there is a response.
Right. If there is, say, to the clinicians, this question is to the clinicians, if the one particular patient, say, is found to be a non-responder, as Dr. Jyoti mentioned, that there are occasional cases where, even clinically as well as on ultrasound, you may not find the response which you are expecting. Then what has been, your next line of action? A surgery or some other like other immunosuppressants we have already discussed. Is it surgery or what else do you
So we try all the
suggest?
options actually. So try oral steroids, intralesional steroids, immunosuppressants, and in fact, I've even tried homeopathy. I mean, I don't give it, but I refer to the consultant.
Right.
And I've discussed it with the homeopathy consultant, and they are quite confident about it because they do deal with the autoimmune diseases.
Yes,
So
yes,
they also start simultaneously while the patient is also on steroids, and we both monitor it together. So that also has helped in a few of my patients. I mean, I would say almost 10% of the patients it has helped. I don't know because of homeopathy or not, but yes, this is one
right,
option. And surgery, of course, remains the last option.
right. So what has been the I'm sure you all agree with what Dr. Anupma says.
So
So what
Vishali, if
yeah,
so, what Jyoti said, I think that is very important to understand. You get these micro abscesses. So these
yes.
micro abscesses are walled off. You can keep giving them, pushing them antibiotics. It just doesn't work. And once
Correct.
you've seen that it is not working, then the only option, that only recourse then is surgery, because you're not going to get away with it, because it is going to keep flaring up, keep subsiding, keep flaring up, because these micro abscesses don't go away with
Right.
those tracks that Jyoti mentioned.
And I think they keep on coming with the multiple discharging sinuses, and the life of the patient is really hell. So, what has been the extent of the surgical procedure which you have been doing? I mean, the next question is, of course, have you ever done a mastectomy for a patient with granulomatous mastitis?
Not yet. Not
No,
yet.
no,
Okay.
no.
So, do you do the debridement and removal of all the necrotic part, and
Yes.
do you leave the raw area for secondary healing? Is that the option, or you close the cavity over a drain, or what has been your practice?
So close
So
the cavity. Try to close the cavity. I mean, take a wider margin and try to close the cavity.
Try to close the cavity. That means
Yeah.
you go for a very wide excision and all that. Is that so?
Yeah, that's so, but that's the last option when you are not getting response from any other. So basically, it's a combination. You give antibiotics, intralesional, and then you start oral antibiotics, and try to, I mean, make it the size you want to excise lesser amount volume. And
Yeah.
when you think that it is now the least volume you are excising, then only surgery is the option. And we try to close it always.
But here we are talking about
I don't.
those who are non-responders, sir. When the disease is quite extensive, in that situation, you are really in a fix as to how much to exercise, and you end up, causing a lot of breast deformity, isn't it?
Yeah.
So we don't close
So
actually.
I don't close. I don't close
Yeah.
either.
Even we
Right.
don't
I would
close.
pack the cavity. Yeah,
I
I would
Yes.
pack the cavity because you will see. I'm sure you must have all encountered it. I think we all get wiser with time. You could be
Correct.
packing the cavity and suddenly you'll see another lump coming up just adjacent to it.
Absolutely, absolutely. This is happening.
And then these are practical issues that you face, and then you say, "Oh God, now what?" So you put in an artery through that open cavity, and try to drain that thing into the main
Correct.
cavity. So we've all done all of this. But I
Yes,
think
yes.
cosmetically, your packing thing works well. So I always say, when you pack the cavity, suppose it is a peri-areolar or something, just try and place the nipple, and you'll invariably find a lot of this happening around the nipple areolar complex.
Yes,
So
yes.
I would
Very
raise
areolar.
the nipple and keep it on top of the pack, so that doesn't dive in, and then the deformity happens. Because then you have to do a lot of mobilization when you're stitching it back. But I would say 4 to 6 weeks of packing. Unfortunately, this is what you're preparing your patient for when you're doing the conservative treatment. And if worse comes to worse, I have to operate, because she's also seen that you've tried your best to treat it conservatively, not working. And then when you finally do the surgery, you're mentally preparing her for a 4 to 6 weeks of daily dressings, which is quite a painful thing for the patient.
Yes, yes.
So obviously, when there is pus or it's wet lesion, then only you will not close.
Yeah,
It's only
definitely. Only if the lesion is very small and, yes, then I agree that you can maybe do a primary closure, but those occasions are not very often we come across. Yeah.
So one more thing, Vaishali, I wanted to
Yes.
say, in recent times, we've started doing total duct excision along with whatever lumpectomy, quadrantectomy we are doing.
Absolutely.
Because see, everything, the pathology starts from the ducts.
Mhm.
And
Okay.
I have realized
Completely.
that doing a total duct excision helps along with the
Yes.
debridement of all the necrotic tissue and the affected area.
You mean in terms of preventing the recurrent? Is
Yes.
that so? Okay.
Yes.
Yeah,
Yes.
absolutely.
Okay.
Absolutely.
Yeah. So there have been
Even
quite
I
a
do
few
that, yeah.
papers recently actually on this, that total duct excision may be an answer to preventing a recurrence.
Okay.
That's right.
Right. So, we are actually coming closer to but before we close, I just wanted to understand from all of you. The literature says that it is a, self-limiting condition. But for me, my patients, I have not been able to, follow any one particular patient for a long time. So my understanding about the natural history of this disease or the progression of the patients is actually very limited, because patients usually do not come back to me. So what has been your, follow-up or experience in terms of how many patients do eventually get cured of this, nasty problem? And what has been, have you seen or followed some patients on a very regular basis and seen that they have now, been cured of this disease? Dr.
Yes,
Geeta?
yes.
Oh, yeah. Dr. Anupma, you wanted to say? Please.
Yeah, so I would say after doing whatever we have to do, approximately 60% patients would come back on follow-up, 40% would be lost to follow-up. And amongst those 60%, I would say at least half of them would be, cured within a year. Approximately a year is an average time that I would say for cure. And that might include all the modalities of treatment.
Any different?
So I've had reasonable follow-up. Like I told you, this patient of mine who's about 3 years now, she came only today with another thing coming up. So I'm very clear in my mind. I'm not actually thinking that it is going to be cured unless it is a small lesion, which is likely to get cured. But if it is a largish lesion, there is every possibility that she's going to come back. And I keep instilling this also in my patient's mind, that it has a waxing and waning pattern. it is something, and I said you can travel the whole world and you'll get the same answers. The antibiotic may change, but effectively, most of the everybody is at their wits' end as far as granulomatous mastitis is concerned. We keep making this effort to, and Anupma was actually had suggested a couple of years ago that we should be trying to run a trial wherein we put in all of these modalities, see what an arm which has got antibiotics and steroids, another one which has got the immunomodulators, and a third one where there is surgery or something like that. It would have 4 arms, and I'm sure with the kind of numbers that you're saying, I think we should be able to give an answer to the rest of the world, because the whole world is struggling with this, I can assure you.
Absolutely. I also wish that something like this happens. Dr. Goel.
Yeah, I just had 2 or 3 questions, which if you allow, then I would just ask.
Sure, sir.
Okay. So firstly, let me say, Dr. Anupma, how would you define cure in a patient of IgM? How would you define cure?
So in a few papers that I've gone through, including some meta-analysis on this issue, approximately 12 months of no symptom, similar to the earlier ones that she had. So 12 months of remission, complete remission, is defined as cure.
So remission meaning absence of any lump, or
any
is it just...
symptoms, no symptoms at all, complete resolution of the previous disease.
So no lump and no symptoms.
Nothing at all.
Okay. And Dr. Geeta, do you think the incidence of IgM is increasing, or we have just become more aware? We are making more diagnosis because of awareness, or?
I think more than half of these patients had gone on ATT earlier on. But now I think we are making the effort to diagnose it, and I think we're seeing it more often also. It is not as if because I remember in the last 3 or 4 years the incidence is definitely seems to have grown, because I'm seeing quite a bit. And what Anupma says is another, because she's seeing a lot more than we are seeing. So I think there is something to the growing incidence also.
So, and we don't know what would be the reason if the incidence is actually growing, so that we don't know. Okay, and Dr. Anand, let me ask, sir, the situation that a patient comes with the outside FNAC report of carcinoma, and then clinically you think it's actually not a malignancy, then would a single biopsy which is negative give you the confidence to sort of reassure the patient, or how do you feel confident enough to assure the patient that there is no malignancy actually?
Obviously, if patient has gone outside core biopsy or something, then we will like to either review the blogs or slides, or we will do seek repeat biopsy from that lesion under maybe palpable or ultrasound guided. And once we are quite confirmed with your pathologist that it doesn't have a malignancy, then only we will assure the patient.
So basically, if you are able to review outside material, in case you are not able to review outside material, a negative biopsy in your own setup is sufficient?
Yes, if imaging says that, imaging also we have to take into the consideration.
Yeah.
So I think
so
it
Dr.
will
Goel,
have to be clinical.
I would do it differently.
Yeah.
Yes. So if it is negative, so I told you this patient came with a diagnosis of a ductal carcinoma on FNA. We did a biopsy, it categorically said chronic granulomatous mastitis. Then I would stop. But if it does not give, just as you said, if the biopsy is negative, then I would err on the side of taking
biopsy has to be negative for cancer. Biopsy has to be negative for cancer. Then there has to be something on the biopsy. Pathologist has
if
to
it
give
is not there, I'd rather go and operate her. Because somebody coming with an FNAC report of a ductal CA, you have to make a better attempt to figure out what it is, because I would not be comfortable leaving her alone.
So the basic question is that fear, even 1% fear of missing a malignancy somewhere in part of the breast, that fear is going to be there. So there was also this important, because so many times you find a slightly sort of prominent or large lymph node. So whenever you are going for a biopsy from the lump, do you also ask for a FNAC from the lymph node?
I do, yeah.
Yeah.
So this is the situation which I was actually looking for when I asked you what is the condition, what is the particular specific situation where you would go for surgery surgical intervention first. When, there is a discrepancy between the outside report and the, your institutional report. If it says negative, then probably I would also rather, operate on that patient and be 100% sure that, you are not actually dealing with malignancy, because that is what the situation we are going to really repent in,
Dr. Jyoti, you always do a FNAC from a axillary node in such cases, or?
If the clinical, like it depends what I'm seeing on imaging. If there is a clear cut case of cancer, and if the nodes are like really huge, 4-5 centimeters, really palpable, there is no hilum, then there is no doubt about it. I wouldn't, those patients have to go for clearance. I would not go for an FNAC for those, but the ones which are indeterminate, yes, I would go. But if it is a granulomatous and the clinical picture, the imaging picture, and the biopsies are saying that it is granulomatous, then I know it is reactive nodes are expected. Then I don't go for a FNAC for those. But when I am myself feeling that this can be malignancy, I have a high suspicion of that, then at the time of biopsy I would do a FNAC
No.
also.
So
But
the
most
basic
of the times the picture is like with with our experiences we are getting wiser and wiser. So a lot of times I would say yes, it looking more like granulomatous, so I would hold on. I would not put a needle into lymph nodes, but if
Okay.
I feel it's more likely to be cancer, then I would put my needle into the axilla as well in the same setting.
No, so basically, as a surgeon, it happens sometimes that we have a lump without sinuses and all, and a prominent lymph node. So
Yeah.
in such cases, even clinically, we are sort of worried about malignancy. So
Yeah.
FNAC from the node also being reported negative can give us a added level of comfort to reassure the patient.
True.
That was the basic reason.
Yeah. So suppose if on the imaging I am getting a very clear cut picture of abscess,
Yeah.
then I would not put a needle
Then
on
you
it.
would not put a
But if
needle on it.
if the findings are not clear cut, it could be either way, then I'll put a needle into the node as well. Because
Okay.
all the cases of granulomatous mastitis, or for example any abscess, they would definitely be having enlarged lymph nodes. So there is no point putting needles in those when we have a reason right there in the breast to suggest why this lymph node is enlarged.
Okay.
But if I have a doubt, like this can be, many a times the necrotic tumors are looking like abscesses. So so nowadays we have elastography as well, and elasto helps us a lot. So if again I am pretty confident this will come back as abscess, then I would not put my needle in. But if I'm wrong and it comes back as cancer, then in the second sitting I'll be going and putting a needle into the lymph nodes. But not if I'm pretty sure this looks like an abscess, then the reason of enlarged lymph nodes is right in front of my eyes and biopsy has confirmed it, so I'll hold on to a axillary lymph node FNAC then.
Okay.
Ma'am, can I ask a quick question, small question?
Yes, please.
Whenever you go for a lumpectomy, what margin do you expect us? I mean, is it 1 centimeter? The clear margins.
There's no mention about any, margin.
No, I don't think in IGM you are talking about a clear margin as such, and probably sacrificing too much of tissue may not be really worthwhile. So removing all the gross lump and not really focusing on all the edema around may be better in terms of the long-term cosmesis, and leaving the wound open to sort of heal by granulation might be a good approach. That is what I feel personally.
Yeah, the literature does say that, taking the, affected area with a healthy margin of breast tissue, especially in, smaller lesions, has been
In
found
small
to
is
be,
different. Small is
yeah.
different.
But there's no such,
We are
margin.
not supposed to report because, ma'am, we get the lumpectomy.
Yeah.
Dr. Anupma, the patients who are cured, do you see a pattern in terms of what is the time in which the cure is achieved? Is it that patients who are getting cured happen to have an early response and early cure vis-a-vis those who... Is this? You're mute?
The severity of the disease will actually determine the time it takes for the cure. So obviously the milder cases, I would expect a response in 3 to 6 months for them to be absolutely all right. But these mild cases are very few in numbers. What we see are actually the moderate ones or the severe ones who've like gone through a lot. So for them, I would tell them that it might take even up to a year for you to kind of get out of it, maybe a year
And
or more.
when would you decide to discontinue medical treatment? Say after response, any further period of treatment?
So after response, when we are assessing the patients on clinical examination as well as on ultrasound, I should get a report from even from the sonologist saying that all the previous changes have resolved.
Okay.
That would be the time that I would kind of, I would of course start tapering earlier. When it is already resolving, I would taper the steroids earlier and the medication, but I would stop only after radiological remission is there.
And
Arun, sometimes it is very difficult because some small radiological changes, residual changes, they remain for a long time.
Okay,
even if the patient is asymptomatic.
Yes.
So what I do if the patient is asymptomatic virtually and a small like a centimeter or centimeter and a half residual disease, residual sort of changes are there, which are stable over a period of next 2 or 3 months on ultrasound. Maybe today I have repeated an ultrasound after 8 weeks. I think that is the time I should stop the treatment because I can't go on giving him sort of steroids or something beyond a limit. And of course, yes, 20 to 30% patients, 40% patients do recur sometimes. And it is very difficult because now we have almost experience of more than 50 to 100 cases in the last 5-6 years. So it's a very difficult situation. On day one, we have to explain to patient it is easier to treat cancer than granulomatous mastitis.
That's correct. And then how do you keep on monitoring? Do you get ultrasound done, say, at regular intervals to catch them at early recurrent stages, or what do you do?
If 2 or 3 ultrasounds over a period of 6 months are stable, we don't do any more unless the patient becomes symptomatic. And even the patient will not come if they are not symptomatic.
Yeah, correct. Is there anything else?
I think time is
yeah. So, Dr. Goel, can I request you to conclude?
Yeah.
Thank you, Dr. Vaishali. First for a comprehensive talk and then for a very comprehensive panel discussion. I just chipped in for some personal queries of mine, but I would like to thank all the faculty here, Dr. Anupma, Dr. Geeta, Dr. Swagat, Professor Anand, Dr. Jyoti, Dr. Kavita. I would like to sort of thank all the audience and the message is nearly 150 delegates have logged in the program. So overall, a very enthusiastic response. It basically, it shows that this webinar model has an important role to play in the long run also and should stay because all meetings being physical is always a problem. So it gives us an opportunity to connect with a lot of people from a lot of different places and the audience also from so many different places. So this was the 31st webinar and we hope to continue bringing you more such interesting topics as we can find. The thing is that after 30 webinars, it is possible that we may have to recycle some of the earlier ones, hoping which ones have new information to share. So, and thanks a lot to Mice Ideas for doing a nice job. Thank you, Dr. Rajiv. Also, in spite of being unwell, you've been there continuously. Thank you.
Thank you.
Thank you. Thank you so much.
Thank you.
Thank you.
Bye-bye. Thank you.